that's great. As people come in, we'll just let them in and let them join. We've got the chat open. We are recording just so that everybody knows, and you can talk to Naomi about that. Otherwise, I hope everybody's doing great, able to get a little bit of sunshine this summer. Welcome to a parent panel on education, including parents and families in palliative care. We have kind of this boomer. Oh, wait, I'm not supposed to jump in. Naomi, I already forgot. What was I going to do at the beginning? Did you want me to welcome? And
you can jump in. You can do whatever you want. Oh,
okay.
At the beginning, I think we have a small group. I'll put it in the chat, but we can invite people to put in the chat, like who they are, what their role is in education, and where they're joining us from.
Yeah, that was it. I'll start, actually. I'll throw it in there.
I can put it in the chat. You can.
Yeah. All right.
Great. You kicked us off. Thanks, Becky.
So we have a great opportunity today to kind of learn about what some people have kind of coined the term a little bit of a boomerang relationship in palliative care. It's one of those things that families are one of those things that we might toss and they just come back and they come back and they come back. And palliative care is one of those few specialties where we really get to develop that integral relationship with families and with encouraging them to be part of the team. And as we look at educators in palliative care, educating parents becomes one of the roles that we have too, and also being educated by parents. And so both of those is kind of the context for today. And we hope you guys feel free to, we'll have some question and answer time in between as well as at the end. And then we hope, if nothing else, you guys are able to walk away with some really good hands-on tools and things that let you share with your team, and even as importantly as share with your families, so that they have things that they can do to really be empowered to join the team and foster that two-way exchange, enabling parents, enabling siblings in being part of that medical team. So we're going to start. We've got a great panel here. We've got three parents and experts in their own right. We've got Rachel Ortega, who is a mom of a medically complex kiddo and a fierce advocate. And from her, she has absolutely educated me in the importance of hanging in there to be sure everybody understands each other and everybody understands things. So she's going to do a presentation. And then Colleen Kenny is also a mom of a medically complex kiddo whose every day is different and is driven by her diagnoses. And she also works for a family-to-family network and is going to talk a little bit on how to connect families just by sharing a link to a map that goes nationwide that they can then go from there on their own and find resource in their area and find support from other families. And then our final parent is Tristan West, who we've worked with for a long time. I kind of call her a rare disease champion, both her and her son. And we're excited to hear from all three of them. So Rachel, we'll turn it over to you.
Thanks, Becky. My name's Rachel Ortega. I live in Salt Lake City, Utah, with my husband and my 2-year-old son with a severe brain injury, which comes along with the laundry list of diagnoses that come from brain injuries. So we are very familiar with the hospital and everything that comes along with that. So my focus today is on how to educate your palliative care team and other providers on the children they serve through the eyes and knowledge of the people who know them best, which is their parents. Including parent advocacy as a piece of education is crucial. I believe that the relationship between parents and providers is most impactful when it's grounded in mutual respect and shared responsibility for the child's care. I've seen firsthand how much more respect parents get when they're able to clearly and concisely portray and communicate their child's needs and daily schedules in crisis situations. Us medical parents have always heard I have a PhD in medicine, but you are a PhD in your child. And you as providers can help educate families and help educate families and help them be prepared with tools that can help them actively participate in these medical team discussions more easily. Today I want to share 3 practical tools that can support this collaborative and educational relationship between parents and providers. These are easy to implement, don't require systemic change, and can be handed off to families with just a link. The first one is a get to know you poster or like an introduction video. When families are inpatient, so much time is spent reminding teams that our child is more than just a list of problems and symptoms and diagnoses. A simple poster created at home and then taped on the hospital wall can humanize a child instantly. It can include a photo when they're healthy and happy, likes and dislikes, and what helps soothe them. This can shift the dynamic from clinical to personal within seconds. We have included a link to a template for the poster that you can share with your families and staff. If a poster isn't available, another awesome tool is just a 5 to 10 second long video of clips of your child playing or happy at home that you can just show providers to help them understand what your child's real baseline is at when they usually only see your child when they're very sick or in like critical situations and not doing great. This also allows parents to relax and stop feeling like they have to present their child's humanity all the time. And now the parent can truly focus on the clinical health concerns and becoming a better part of the child's medical team while inpatient. The second tool is called the Lightning Bug app. This allows families to digitally track their child's medical history, medications, surgical history, and much more. Instead of retelling the same story to each team member as they come in the room, families can share accurate, up-to-date information with just a couple taps on the app. It would be easy for parents to update the app while in waiting rooms or during quiet times throughout the hospital stay. I only recently learned about this tool, and I wish someone had told us about it when we were in the NICU with my son 2 years ago, because it really would have saved me a lot of time, energy, and emotional fatigue throughout the last 2 years of our medical journey. The third tool is a care plan binder. This printable tool helps families stay organized and proactive in their child's care. It includes templates for medications list, appointments, appointment tracking, emergency protocols, symptom logs, and a lot more. The binder doesn't have to be perfect, and it can be built up over time. And you all know those families that pull out their giant notebook or their stack of papers with all the clinical notes and have to search through it to find what they're looking for. This tool would definitely be for them. It gives parents a way to prepare, reduce stress, and approach each provider conversation with more confidence and clarity because they have the tools they need. This can also be easily updated during hospital stays. I've spent a lot of time looking online for tracking tools and any type of thing to help me stay organized, but nothing is ever comprehensive enough for the needs of my child with a lot of issues. And so handing parents this tool will save them so much time and make their life so much easier. And then while those tools are practical and tangible, here are a few like conversational strategies that can further strengthen the parent-provider relationship. The first one is a catch approach, where viewing conversations as, think of conversations not as debates, but as a game of catch. When looking at an email that you sent the ARC.
Can everyone mute themselves? Thank you.
Well, so yeah, think of the conversations as debates, not as debates, but as a game of catch. And when a parent says, this doesn't seem right for my child, it's easy to get defensive. But instead try to like catch that concern, pause with it, and then respond with curiosity. So something like, tell me more about that. This shifts the tone from correcting to understanding, and it helps build trust and encourage a more open dialogue between providers and parents. The next super powerful strategy is redefining language. Words like pain, lethargic, or off can mean very different things to different families and to different providers. Clarifying language is a powerful educational tool. Reflective questions like, what does pain look like for your child? Or when you say they are not themselves, what's different about them? These questions don't just clarify, they are based on collaboration and validate the parent's expertise. Sifting through what parents are saying in these times of acute stress to find the clinical pieces that only the parents know helps prevent these missteps happening over and over again. It encourages the parents to speak up again too speak up again with those critical pieces of information in the future. I know as healthcare providers, you didn't get to be there during the last crisis or the one before, or the patterns that us parents live in every day and every couple months. So when you providers include the families in the medical team, the parents can be the consistent medical team member from occurrence to occurrence, so information gets passed down and communicated that otherwise would have been lost. The last one is reciprocal education. Parents are trained to learn your guys' systems. So in today's session, we have learned how to help your system learn from the parents. We must normalize parents as teachers when it comes to their own child. Every new provider, resident, therapist benefits from learning how the unique child expresses their symptoms or responds to interventions or finds comfort. Empowering parents to share that information as teachers and not just as caregivers improves quality and individualizes care. All of these tools, both tangible and communication tools, can help reduce the fatigue that families feel when they're constantly having to repeat themselves to different providers. It improves continuity and quality of care, and it allows both parents and providers to focus most on what matters the most, which is the children. In closing, every provider is an educator and every parent is an educator as well. When we treat each other that way, when we collaborate, we build care teams that are resilient, informed, and deeply connected to the children that are being served. And that's all I have.
Whoop, whoop. Thanks, Rachel. That was awesome. Thank you. Millions of claps from Canada down south to up north, everywhere. I'm going to share my screen just for a quick second. Sorry, it just took what I had to share, but it's okay. I'll get rid of the mess. So this is the link that you have, that link that I posted, and each of these resources are on here with the simple links. Some we've made, some we've collaborated with Courageous Parents Networks and made together, and some, like the lightning bug, was made by Pennsylvania's Pediatric Care Coalition with Betsy there. This is a simple poster. There's also a Canva link, so families can do it digitally or do it however. And our families have had a lot of enjoyment in making this as a family and then put it on the wall. And it really does relieve their burden of trying to point out how their kid's a person the whole time. The medical app that Rachel spoke about is this one. I did just check with the Pennsylvania Palliative Care Coalition, and it is up and running. And it is what Rachel described as, if I knew this was there, it would have saved all kinds of stress and would have given me a place to put stuff. They also do have that digital care plan book that they made that is designed for medically complex kids. Like there's a whole section right here that's just on feeding, one on G-tube feeding and how to track it. Anyway, these are tools that you can share with your fellow practitioners and residents and whatnot, or that you can share right with families. So those are the ones that Rachel had. Thanks, Rachel. I'm going to stop sharing my screen and turn it over to Colleen.
That was incredible. And I love that app. In fact, we have we have 2 different care notebooks, but you can't like change that information on the fly like that. I can't wait to share that. And then how many of you guys wish that all of your parents were so proactive and had the capacity for that? Well, guess what? My job is to help that. My job is literally to help families learn these types of skills, like, because it doesn't happen overnight. For me, it's taken almost 26 years. So my daughter received an initial diagnosis back in she's 26 now. So literally, before the turn of the century, just kidding, but back in 1999 was her first initial diagnosis. And when she first started receiving early intervention services. And so I definitely like to say that I have not done this by myself. I have not been alone on my journey. And I really appreciate, the opportunities that I've had to pay it forward. And I still do that after, 20 something years of volunteering with local organizations. I have, now found employment at the Utah Parent Center. And every state does have a parent center. So you can find those resource places. But a parent center its main focus is to help families that have kids that qualify for IEPs and 504s, and to make sure that they understand like the ADA parts of those laws for school support. Along with that, most states will also have what's like a Family Voices affiliate or a family to family um, a, a family to family center. And what we do is we provide health and medical resources the same to those same families. We like to define them as children with special health care needs. And we've actually been able to expand that. So it's not just, children who require health and related services beyond that's required by children generally, or who are at risk for chronic physical and developmental. But recently, we've expanded that to behavioral and emotional conditions as well. So we see a lot more autism, a lot more behavioral stuff, as well as our other physical and developmental issues. And what we do is we assist families as they navigate all those public and private healthcare and related systems. So not just private insurance, but Medicaid waivers. That's my specialty right now. Um, safety things like guardianship and Social Security. But we also educate families how to access services and resources and how to build effective parent professional partnerships. I can show you the best website to access to apply for Medicaid. Um, but I can't fill that out for you, especially in systems like Social Security. That's not always legal for me to like fill that out for you. But I can hold your hand through every step of the way. I can sit there and be like, all right, let's fill out number one. You got this. I know you do. All right, let's move on to number two. It's your address. I know you got this. Let's do this. Like that is my job because we want to build capacity. This isn't the first application this family is going to have to fill out. They're going to be doing this and dealing with these systems for their kids for a long time. But probably the bulk of what I do at my job is I listen to families as they describe their encounters with these systems, and I help to guide them through possible solutions. And if nothing else, then every single employee at the Utah Parent Center and at most of these centers work on a family to family model, and that is because just like what she referred to is over time our families acquire knowledge. They acquire that expertise in managing their child's care, and they're able to share that. We want to teach them how to share that best and how to communicate with professionals best. We are the experts at balancing our child's physical needs with their social and emotional and spiritual aspects that lead to those overall quality of life that brings that main meaning to life. But parents can also help others see that the child comes first, the illness and disability will come second. And I do always appreciate when doctors recognize that families of children with special needs have that wealth of experience as consumers of healthcare and those related services, and that we do know what works best and what needs they have. But we also can help them learn how to describe what is and what is not helpful, because sometimes we do have a little bit more passion than is helpfully communicated. So yes, so at the Utah Parent Center, we have lots of other projects, and I'm sure that other states' parent centers do as well. So again, within the Parent Center, we have that parent training and information for school services, and we have a Family Voices affiliate. We also have parents that support with things like, again, our local state's Medicaid waivers. And again, we all work on a family to family, parent to parent model. And that's how we have found to be best. We also provide workshops on things like new diagnosis, now what? So what are the most important services or resources that we need to do or access first? We do things like maturation for parents. That's a big shocker for a lot of parents, that our kids will be going through puberty either, on time or sometimes, early because of medications or because of different diagnoses that they have. And our kids probably won't have access to that 5th grade maturation class. So parents forget about that. And so we help parents to kind of get that exposure therapy. We also teach a lot about other healthy relationships as our kids get older. We help with medical transitions as well. One of the most traumatic things for us as a family, not really, but it was hard, was that our doctors broke up with us when our daughter turned 18. You know what I mean? Like we had to go find a whole new set of specialists, a whole new set of doctors. And we help families prepare for that as well. And again, preparing information, preparing a care notebook to pass on to other professionals would be a great first step, and not having to, dig back through 18 years of information and clinic notes, and having that prepared would be great. Again, even as we're accessing systems like guardianship, Social Security, Medicaid at that age are all things that can be helpful for a family. And those are the types of workshops and things that we have available for families and that we do regularly. So, yeah.
Awesome. Thank you, Colleen. Again, woohoo, woo. Thanks for all you've learned and all you do and being willing to present. I know sometimes as a community-based palliative care provider, we get calls from our children's hospital's palliative care team all the time of how can we connect families to resources? We know we need them and we don't know them, and we can't keep up on all the alphabets and all the things that change and the new Medicaid this or that, but you must know this, so you help them. And so we have, I'm going to share my screen again. We have included 2 things on these links. One is a family to family voices national map. So you can find Pennsylvania and click on that, and that'll bring up what you have available in your state or your area that families can help support families, and that comes off of your plate as inpatient or as palliative care providers that wanting to connect them with resources. These maps will help families find the resources that exist already. So anyway, thank you. That's awesome, Colleen. And Tristan, we'll turn the time over to you.
Okay, hi, I'm Kristen West, and I have a son who's now 13. He is very medically complex and has a syndrome called MCTT syndrome. He's one of 25 in the world, and he was the first one found with that genetic mutation, and it wasn't described in literature until he was 8 years old. So we went many years without an official diagnosis. And we began working with palliative care in inpatient at our children's hospital when my son was maybe 3 or 4 years old. And then we connected with Braid's Place in Becky in July of 2022 when Jason was about 10 years old. There were a couple of tools and strategies that were big game changers for us when we started working with Braid's Place. And one of the things that really helped us work together as a team and move forward with improving Jason's healthcare and quality of life was mapping his body systems. And so we went through system by system, and it was very helpful because in those 10 years, we'd been told many things, been given many little diagnoses. It gave us an opportunity to dive into some of those, find out which ones might be medically significant, which ones were crossovers across different body systems. And it really helped Becky and the palliative care team get to know Jason quickly because he's a very complex patient. It could take me 10 years to explain those 10 years of things that we've learned about him. And you can't just find him in a medical journal. And so it was very helpful for her to get a comprehensive look of what we're dealing with system by system. And then once we were able to look at that, we were able to more easily discuss meds and the different medicines that he was on, ones that we had tried in the past, ones that might be available, and potential medicines for us to try in the future with some of the problematic issues that were still occurring. And so that helped us kind of hone in and focus and then connect the medications that he was on. It was helpful to make sure, you know, when sometimes as a parent, your kid has all these complex issues and they're on this wide array of meds, it really helps to go through, break it down system by system, and make sure that each one is serving a purpose. Is there one that we could increase instead of adding a new medication, those kind of things. And it helped to start with that mapping of the body systems. It also helped us when we were looking at then the specialists that we were seeing. So I think when we started with Becky, I think Jason had 20 specialists that we were trying to work with and manage. And when we're looking at the body systems, we were able to talk about, okay, especially which symptoms and which body systems were still really giving us trouble, were affecting his quality of life, which ones were causing him to be inpatient or have frequent ER visits. And we could look at those specialists and see which ones might be worth looking at a different specialist. Sometimes looking at Becky would know, oh, I know this doctor and they work with this body system and this body system really well, and it seems like those are related. Maybe we could reach out to this doctor, or let's ask some more of these questions from this specialist. And is this a specialist we need to follow up with? Has it been too long? It really helped us in those dialogues of looking at where we were, because as a medically complex parent, it gets so overwhelming, and we're in the thick of it every day. So all day, every day, we're trying to keep the kid alive. We're trying to keep him happy and content, make family memories. We're trying to manage our other children. And the big picture stuff sometimes just feels really overwhelming. So to have someone to sit with and talk body system by body system, medicine, and go over the med list, talk about specialists, it really also helped us see the importance of having a pediatrician that could manage well all of the different body symptoms that we were dealing with. And that was a conversation that we had that was hard, because we'd been working with a pediatrician for many years. We've grown to love him, but it was frustrating in that we had seen that there were many things that should have been able to be handled locally without having to go to the ER so many times, without having to always resort to specialists. And so we were able to have some conversations and change pediatricians, and that was a huge game changer for us. And so by starting with the body systems, we were able to make a lot of good progress there. The last thing I wanted to talk about was an anticipatory system checklist. We wanted to take Jason out of state for a long trip. And our biggest concern is, like, what do we do if it's already so hard anytime he's inpatient at our local hospital with people that are familiar with him? How would it be if we were needing to go outpatient? And he's so complex, nonverbal, doesn't respond the typical way. And so we went through things and we looked at main causes for what might cause Jason to be hospitalized, the symptoms that he has that are complex, that don't present typically, and maybe some of the things that would extend his stays. And we describe those symptoms, and then what treatments typically work, what things we know don't work or he has an adverse reaction to, what it looks like when things start to get better, what it looks like when things start to get worse, and what some of the bigger intervention steps are. And then we focused on each of those major symptoms. So for Jason, it was autonomic nervous system dysfunction, pain, seizures, constipation and vomiting, metabolic acidosis, urine retention, sleep, and immune deficiency. And so by by charting all of those and going through and making a plan, I felt very safe and secure going out of state, and felt like it was instead of a whole binder of medical notes and saying, oh yeah, there's this one time when this happened, we had something in a document that we felt that if we were impatient, I could hand to someone, and if they weren't familiar with Jason, it would give us a really good starting point, so we wouldn't have to make mistakes that we've already made inpatient and try things we've already tried. We'd have the level of care that he needed. So that's something that allowed us to travel and feel confident in our travels, and I was very, very appreciative of that.
Awesome. Thanks, Tristan. Yay, good job. And thanks for sharing, you and each of our parents, really practical ways that palliative care has helped educate you, educate your team on your kid and on life and what it takes to do it. I want to share, it's what we don't have any tip or any takeaway for mapping out the body system that Tristan talked about. And it isn't quite the same as going by specialty, because specialty sometimes is a little more narrow than a body system, right? But because we took him and again, in community palliative care, we have time to do this, right? I know Tristan mentioned the other day, gosh, you know, the time you spent at my kitchen table mapping out his whole body. But honestly, at that point, her son was probably 20% stable and 80% not stable. But give it mapping out body systems, getting a primary care who felt comfortable taking him because he had a good supportive team and he had all this infrastructure already built, and he was daring and like, yeah, I think I could do some of this. It let that new pediatrician feel like they were supported. We were able to educate that pediatrician that way as well. And in doing that, it give it 6 months, 9 months of awesome care at home and stabilizing and finalizing some of those things where probably, I don't know, 70% is he's stabilized, he's back to school on a regular basis, and palliative care was the key, and educating other providers, educating pediatricians, and Tristan educating me is what it took to get that. I'm going to share my screen and just show you this patient anticipatory symptom plan is something that we made in partnership with Courageous Parents Network. They asked us to make a travel packet with them for families with medical complexities who wanted to travel, that maybe they could do it safely. And what we realized was that at home we have orders, at home we have people who know us. And so we created this during that same time so that we could do something not official, but something very specific. And it has an example at the bottom of here's the dysautonomia, what that looks like at baseline, how that responds to typical treatments, when symptoms increase and worsen, and what you should do about that, or what you could do, or what works at home. And this is also great for even when you're not at home, frankly, and you end up going to a different hospital, or people on site don't have experience with you, as can happen often in urgent settings. But it is it also, when you put something in writing, it really hones it in. So we included that, and then we also did include a link to the travel package that we made in partnership with Courageous Parents Network, and they were cool enough to also put it into Spanish for us and with us. And so it goes through airplane ride, car ride, what to do at your hotel, how to have equipment shipped to your hotel so that you don't have to take a million cases of feeding with you. It really handles a lot of really awesome things. And so we're really excited to open this up for some parent or some questions to our panel, but also want to thank you guys for all the work that you do inpatient and as palliative care providers to help their health be the best that it can be, because that's what matters. And thanks to the parents for sharing the tips and tricks of what has worked in palliative care and helping us know how to better participate as a team and educate both each other and families. So do you guys want to just unmute and ask questions? You can throw questions in the chat. What questions do you have for our parents? or anything else you want to chat about or talk about more in depth? I know it's hard as a group and even harder when it's virtual. Christine, go ahead.
Hi, so first of all, thank you so much. I know I'm speaking for everybody. Just first of all, thank you for letting all of us take care of your kids with medical complexity. We know that we're all coming in a lot of times in really tough times. So thank you. It doesn't go unnoticed from our team for doing that. But I guess my next question is, I'm sure that pretty much everyone on this meeting, the care teams, like we're here because this is what we do and this is what we love. And we frequently are the people that are like kind of ranting and raving to the primary teams. Like, do you know what this child's baseline really is? Like, do you know that they do this? And they're all shocked and, what? And so how do you, I mean, you have these great tools, but besides waving your phone in someone's face and saying, look at this video, what is the best approach that we can encourage families to advocate and sort of help and show themselves if our team isn't there at some point?
Let me start. Thank you for that. That's awesome. And a really valid thing is we can't always be there and empowering our parents, educating them on how to speak. I'm going to lean into something Rachel said, and we learn it in narrative medicine, is to not repeat back what we heard, but ask for more. Tell me what that means to you. And parents can be encouraged to just step back and listen and then say, can I tell you what his baseline usually is? And even that will just stop us in our tracks and say, well, of course it's the standard. Well, no, it's not the standard. Can I tell you that? Or I know you're saying you thought he had a great night. Can you tell me what great night means to you? Right? Leaning into those questions that ask for more information and then kind of helping parents view it that it's just a little game of catch. I liked that too. If it's just a little back and forth, it's not, it can always happen again if it needs to, if it doesn't go well. Like there's no burden. Like a lot of times I think parents feel like if I don't get them to know this, something horrible could happen, right? Or I'm already at my end. And I think just encouraging parents to take a breath and know what you just said at the beginning, that we're all here because we care, and that resident is there because he cares. He just needs a little bit of help knowing that he's got to listen again or differently or whatever it is. So I think encouraging communication. We do parent evenings once every other month. And we do a narrative process and we do it with each other. And, 98% of our parents after the second one said they felt like it made a significant difference in working with their medical team and communicating with their medical team. So I think that learning to ask those open-ended questions and feeling empowered too is great. Parents, what do you think?
I think that's exactly what I would say, because again, like a lot of my verbiage, I will admit, is very relative. You know what I mean? Or if parents come in and say, oh, if you do that, he's going to go crazy. He's going to, what does that look like though? What does it mean when that happens? Because again, like Maya is okay with blood draws, but she is believe it or not, but she's going to be loud and it's going to sound really bad. And so again, like we go in for these blood draws and stuff, and people are so afraid of it. But I'm like, is she resisting you? Is she actually even flinching away? No, she's screaming and she's saying no, and she's saying, but really, like, it's not a pleasant experience, but she's not trying to get away. She's not flinching. She doesn't want it done, but she understands that it has to be done, like just watch her and listen, but don't take for granted that just because she's screaming that it's a negative behavior, if that makes sense. Like, so I do have to warn them, like, it's going to sound so much worse than it really is, and I apologize for that, but I'm not going to tell her to calm down or to be quiet. This is how she's processing this feeling of what she knows is going to happen. So again, I'm not going to come in there and be like, she's going to lose her mind, she's going to go crazy on you, because that's a relative, that's very relative ways to describe behavior. Like, what does it really look like? Well, she's going to scream and she's going to yell. She's going to tell you no, but she's going to be compliant. She's going to let you do it. She'll even probably show you which arm or which hand she wants it done in, but it'll sound really scary.
Yeah.
I want to add that I have also had a lot of growth in communication with doctors after working with the narrative process. It wasn't just a tool and a practice. It opened my mind to a whole new way of thinking, because I had grown so accustomed in our situation to feeling like things that I was being challenged. It was like, well, we typically don't see that. And I'm like, and then I'd be like, I know, but I'm not making this up. And I'd get defensive and challenged. And so by looking through and practicing through the narrative process, I was able to take a different approach. And oh my goodness, how it changed conversations and how it changed me and my anxiety in these conversations. Huge game changer. And I learned for me too that one of the tools, what I need to do is when I'm feeling like I'm not being heard and we need to have some more clarifying conversations with the team, it's hard because you've got this 5-10 minutes with them, and then they decide what you're going to do the entire day. So there's a lot of pressure in that conversation. I ask them to sit down. So I have the benches and things prepared, and I'm just like, can we sit? And there have been times that I literally have pulled out my phone and say, I want to just show you this video. I know that you don't have a lot of time, but I want you to see what Jason is like at his baseline. And then I've learned to ask questions through the narrative process. Things like when doctors are saying, well, we're not really worried about that lab. Normally I would be like, well, I am, because if you go back to these experiences, but instead I could say, what do you mean when you're saying you're not really worried about this lab? And then they can say, well, typically this is what we would see when this, and I could say, I can tell you on these dates, this is what's happened when Jason's been in those situations. And it's really calmed the conversation down and really made it easier. So those strategies have definitely helped me. But the big thing for me is like, I need to feel heard. So we just need to sit and have a minute where they're really focusing and hearing what I have to say.
Awesome. Thank you. And I think that answered the question in the chat about how did your approach change, Tristan? I don't know if you saw that, but literally while you were talking about that, she answered that. And if I'm not mistaken, before Dr. Dickey's accident, she had worked in their local hospital in Pennsylvania a bit. She had done some work, and I don't know in what hospital. And then we did a pilot. So if anybody's interested in having your team experience that tool, Braid's Place would be so happy to join on Zoom or virtually and have your team do a narrative that is palliative care driven, that is driven towards helping families to learn that narrative approach. And your team will feel better after anyway too. So anyway, that's always an option. Feel free to reach out and we can set that up and collaborate in that way. Any other questions? Or things that come to mind that would help? Yeah. Kate, go ahead.
Hi. Thank you so much, everyone, for sharing your experiences. And these tools are awesome. I'm definitely taking them back to my team. Kayleen, one of the things you mentioned was your breakup. And we've had a few breakups lately that have gone really not well for the receiving end in adult palliative care, adult services, for a different population of children in palliative care that maybe 10 years ago weren't having to make the transition, weren't living that long. So I'm curious about that. I'm working on a study on this, families' experiences of this right now in Calgary, but I'm curious to know, is there an age that you'd recommend we start preparing for that transition with teams and with families? What advice do you have?
Yeah,
14.
We say 14. I mean, and again, that's when they're actually supposed to be starting these conversations with them, with families at school as well. In Utah, at the Utah Parent Center, we have a whole curriculum called Transition University, and that's when we suggest that families start thinking about that transition to adulthood in general. And that is when we also want them to start thinking about, okay, what specialists will we have to change? What providers will change? I mean, that includes our dentist. We had a pediatric dentist that was, I mean, he was a developmental specialist. He also was her orthodontist. Maya was able to get through braces with this man. And now, we have to find a new guy to even just do, just cleanings. And it's very difficult. Transitions are hard for families as well as for these kids. Um, but also you have this safe environment at these children's hospitals with these really very, very incredible specialists that you don't find out in the adult world very often, believe it or not. So again, it's very difficult. And so we do try to prepare families for that emotionally, but also, you need to start looking for these providers a lot earlier. There's actually a website, it's gottransition.org, and they have tons of really great resources. We pull those in for our kids and um, for our families, but there's also provider information and provider resources too, and really great videos as well. So that's one that we utilize. It's not like a local resource that we've pulled from as well.
That's great. Thank you so much.
Mm-hmm.
I put my question in the chat, but I'm just going to speak my question. And then,
Yeah.
Becky, I don't know if you answered Jory's question I see in the chat, but I don't know if you want to speak about it some more. But on the question of transition, it can be a really delicate subject because we do care for very fragile kids who, on the one hand, you can imagine that they really will not live and not long enough to transition to adult medicine, but then they may. And we do that dance and figure out what is the right moment, because it also feels unfair for them to start teaching them about transition when we know it's likely not going to happen. On the other hand, it feels really unfair to then do it all at the last minute. And then you're like, oh, they're so fragile. Is it fair to transfer them to another team? I suspect there's no answers, but it is another, I think, unique thing that we deal with in palliative care, and probably there are some other subspecialties that deal with something similar.
Yeah.
I know that, again, here in Utah, just as a local example, some of our Medicaid waivers were built specifically for those children. Some of our tech-dependent waivers were built specifically for those children. And literally until the last 2 years in our legislative session, they've had to expand our tech-dependent waivers to include adults. So kids that were on our tech-dependent waiver, it was meant to expire on their 18th birthday, because by then they assumed that they would either, have passed away or would possibly be onto a different waiver or would qualify for a different waiver in our state. Well, that's not happening. These children are living over the age of 18, that who are trached and who are very, very medically fragile. And it's literally only within the past couple of years that they are extending those individuals' lifespan. So again, like my friend who worked at the parent center, her son is in that population right now where he was at risk of losing his Medicaid waiver because he was aging out of that. And they have expanded our tech dependent waiver so they can remain on that over the age of 18, but it literally wasn't built for that because they did not expect him to live that long. So again, like, yes, this is very, very recent issues in legislation for kids who are, yes, now adults, but and it's hard to find these resources for them and how to navigate that system.
Yeah, thanks. And I think also, Naomi, just like we never touching those DNR and all those conversations well before parents want to touch it and they're ready, we just touch on it and step back, and we touch on it and step back, and then we touch on it and say, hey, what would you like to do right now to get a glimpse into that? And maybe it's that they want to meet that adult doctor. And so then we set up a time before their next time to come into clinic to go to that adult clinic first. And hey, I know his favorite snacks is whatever. I'll give you that. And you can take it to them when you drop in and just see it, just feel it. Right. And so I think, Naomi, just little by little is how we do it in the community setting and then what might pertain to their current developmental stage that could include adult stuff so that they get a feel for that transition and what it would look like, but developmentally relevant.
So you titrate your teaching.
Yeah.
But
and
also don't
like,
keep a 26-year-old man in a pediatric setting just because,
Yeah.
you know what I mean? Like, make sure that those years are quality of life, you know. That would also be that,
Yeah.
but that's as a parent, that's how I see that.
And I think too, there are things that we in pediatrics are experts in, but as these young adults age out of what our expertise is, they really do need physicians and Ps, whomever it might be, that do take care of some of those more adult problems that we sometimes just overlook. And that's kind of what we were finding with when we were getting kids. We don't, at the Cleveland Clinic, don't often transition because there's not a lot of physicians to transition to, but until like early 20s. And quite honestly, it really wasn't like that. You know, even when I started here many years ago, we still had much older patients, but then our residents can't take care of them on the floor. Their training license only goes up to 26. And so then that poses problems of then who cares for this person, but this doctor is always taking care of them. So, you know, there's just so many pieces to it. But I think also just for the best healthcare for a young adult, it should be more of a family medicine adult